I'm Alex Adams. I am from both the University of Wisconsin as well as the Center for American Indian and Rural Health Equity from Montana State University, where I've moved in 8 weeks ago. So, and Scott's going to be presenting with me, so I'll let him introduce himself, and then we'll get started and try and have some time for Q&A.
Yes, good afternoon, everybody. My name is Scott Krueger. I'm the Nutrition Services Director for the Menominee Tribal Clinic at the Menominee Indian Tribe of Wisconsin. I've been there for 20 years, and we've had a 16-year partnership with the University of Wisconsin-Madison. And since we're a little bit behind schedule, we'll let Alex talk. Thanks. Yeah.
Actually, Scott, I think it's 17.
17.
Yeah, that's okay. Who's counting, right? So anyway, we're going to talk today a little bit about an intervention that we designed collaboratively called Healthy Children, Strong Families. And I think I can just go down. So this was community-based participatory research intervention that was designed after we found very high levels of early cardiac risk factors and obesity in American Indian children in Wisconsin. And we decided to work on 2 to 5-year-olds because we were finding these very high rates even very early on, and the community wanted to work early. This was based on an approach of elders and mentors teaching life skills to the next generation. So the first targets that we worked on, I'm going to talk about 2 of the studies. The first one started in 2004, and I'm going to show you some results from that, and then also talk a little bit about Healthy Children 2, which we're on now. The first 4 targets were be more active, reduce screen time, eat more fruits and vegetables, and drink less soda and sugary beverages. Eat less junk food. The first study had 4 participating tribes, Menominee Nation, Lac du Flambeau, Bad River, and the Oneida Nation. And it was a little bit of a smaller study. We had 150 families that started. You can see they were randomized into a home visiting or mentored group, and then a toolkit only group. We also did a matched clinic control at one of the sites in order to see if we had any differences there. And it was a 12-month intervention, either with home visiting once a month or mailed once a month. And then we had a 12-month follow-up maintenance with some group visits. And we'll talk through that. And those are our completers. That's the design of the study. The content of it was designed, hang on. So the outcomes were BMI and BMI Z-score, and then the multiple secondary outcomes looking at nutrition, physical activity, screen time, and sugary beverages and candy. So this is a sample lesson that would go into the home. Usually there was a book or some other informational material about the topic. This was about physical activity outside. There was a lesson plan and then some things like sidewalk chalk, balls, etc., things to do for the kids. So it really targeted both the caregiver as well as the child. We also had group sessions, like this is the Menominee Diabetes Walk. These are 2 of our home mentors that were instrumental in having this study happen at Menominee. And this is a Winter Wonderland session where the kids are getting bear claw snowshoes and learning how to snowshoe at Lac du Flambeau. So our baseline data in the first study confirmed very high overweight and obesity rates in the children, as you can see. Normal weight group, 51% for children and 20% for adults. And the children that suffered from these conditions were more likely to have a parent that suffered from that and was significantly related to sweetened beverage intake and sedentary time, kind of as expected. So we had 150 intervention pairs, and a large percentage of those kids that were overweight or obese at baseline actually decreased BMI by year 2. Did not happen in year 1, but happened by year 2. And of the adults obese at baseline, 59% lost weight, mostly in year 1, and then a lot of them regained by year 2. So as is classic for most adult studies. We did see, we actually had almost no control group because the mailed intervention worked as well as the mentoring intervention, which was really unexpected because our focus group data showed that people really liked the intervention, both in the mail as well as mentored, and really enjoyed having the mentoring. But it seemed like the mentoring didn't have the significant effect that we'd hoped. We did see increases in child's fruit and vegetable intake, which was great. We saw some decreased TV watching, both in adults and kids. And we had a lot of good self-efficacy for change for health behaviors and health-related quality of life, which was really nice. And the communities really loved the intervention, and I'm going to show you some quotes from participants. I won't read these in the interest of time, but you can read some of them. And one of the things that we found that we didn't really expect, or I think we should have expected, but we didn't really plan for looking at it, was increased family time as well as increased reading time to kids. We did send a book home with almost all of the lessons, and that was a really positive thing. And also the child, even a very young child, was a change agent in the communities, working to help reflect on the lessons at the grocery store, for example, with the parents about, oh, we shouldn't buy that, Mom, because it has too much soda. So it was kind of co-mentoring parent and child. So then we decided, after we had some success with that, but really didn't have the control group and wanted to figure out how to make this go further, we also found that sleep habits in young children were really irregular and problematic. We did 24-hour dietary recalls in that first group, and we were finding that a lot of these young kids, remember ages 3 to 5, were up to midnight eating pizza. I'm like, that's not a way to, A, have a child maintain a normal weight, or B, have parents not be stressed. I can't imagine having my 3-year-old up to, midnight. They're going to be pretty cranky. So we wanted to work on sleep in our next intervention and also work on parental stress, realizing that was an important component. We also started to expand outside of Wisconsin, because when I presented at meetings like this, I had so many communities come to me and say, how do we get this? How do we do this? We started to look outside at some of our national partners, and we wanted to do a larger sample. We also wanted to add a social support mechanism, because we knew that the mentors had been really helpful, but it's very expensive to do home visiting, and we'd had a lot of turnover in mentors, and it was difficult to keep them at some of the sites and keep families having the mentors come into the home. So we added social support with Facebook and text messaging, which I'll show you in a minute, and we added a safety journey as an active control arm. And 2 of the communities that we worked with helped us design the safety intervention and add to the stress and the sleep pieces of the intervention. So it wasn't fully CBPR in that all the communities I worked with did it, but 2 of them did help us design that. We also worked very hard on our intervention design so that we were honoring what all of the communities wanted, which was that all the families got both interventions. We didn't have a control group and an intervention group, but we had everybody get everything. So I'll show you that design. So here are the targets, very similar to Healthy Children 1, but with the improving sleep and improving stress management for kids and adults, respectively. Our partners, again, were the Menominee Nation, First Nations Community Health Source in Albuquerque, New Mexico. We had the Blackfeet community, Seneca Nation in New York, and White Earth here in Minnesota. And it was funded by another NIH R01 grant. So the Healthy Children 2 model was to look at, we know that there are many factors affecting health of families and affecting child health in particular. Obviously, community influences, family influences, adult influences. And we had, so on the, I guess it's on your left side, are the factors that we felt like we could have some influence on, and then factors that we couldn't really were more community-driven factors that we weren't, or early life factors that we couldn't really have any influence on. And we had questionnaires for all of these things, and we worked very hard to reduce our questionnaires down so they would not be burdensome, but they were still about an hour and a half of baseline questionnaires and 12 and 24 months. So here's the timeline. You can see it's a modified crossover design. People either randomize into the wellness journey or the safety journey, and then at 12 months they would switch journeys. The wellness journey, obviously you can't take wellness thoughts away, so it's not a true crossover, but they would get an extra year of social network support, and that was text messages twice a week and a Facebook site that was designed particularly for that particular group. We've had really nice, I should say, people continuing with the study. It's been really well received, and we had very low attrition. It probably is a little higher overall right now. That was back in last spring, but we're doing pretty well. We have almost all the communities finished. Albuquerque Wave 2 and Blackfeet finish up in the fall. So I'm not going to be discussing results of this trial because it has not ended yet, and we've not been able to give that data back to the communities and talk to them about presentations. So this is going to be more baseline, but we're learning a lot, I think, that's relevant in the national conversation about what's happening with young American Indian children and their families. So this is a toolkit very similar to before. We did even do more books because they were so successful, so every lesson had a book. We shortened it. And we had the textbook and the Facebook. This is the sort of stuff that goes out to the families, and the excitement of the package has been really well received by the families because it comes directly to the home, and the kids get real excited about it. Here's some user comments. Again, very similar to the first wave when everybody really liked it and spent more time together doing it because the stuff is very interactive and fun and isn't just pamphlets. So gave them stuff to do. So here's a Facebook sample text messages. They had to do with all these different kinds of things. We had thematic, sometimes monthly, and also the site coordinators at each of the different communities were from the communities and could put things on Facebook that were community relevant, like a diabetes walk or recipes, things like that. Lots more green chilies in New Mexico, obviously, than in Blackfeet. So things like that. Outcome measures are very similar to what we had before, but we did look at sleep and stress and demographics. So this is the population that we're looking at. The majority of the families had either an American Indian child or American Indian parent. You can see a very low income group across the board, which is tricky. The majority of the people participating were adult females. Here's baseline weight status. Again, more of these kids were in a healthy weight group than in the previous study, but still significantly problematic. And then here's an important slide. The concern for risk of being overweight or unhealthy weight in the future was very low in this group of parents, despite the high rates in the adults. And then for modifiable risk factors, you can see that as the BMI percentile is higher, it corresponds with, doesn't meet recommendations for more of the modifiable risk factors. And non-modifiable risk factors, being from a rural area, was very significantly associated with having a higher BMI percentile. Some of the other factors we've thought about in the past were less significant, but being American Indian was more significant. And then we found a big difference between our urban and our rural sites in the kids, but not in the adults. So you can see that the rural kids were more overweight than the urban kids, as we've just said. So this is another really important finding, and I think something that we thought was going to be a problem, but we had no idea of the magnitude of the problem. This is based on the USDA Food Insecurity Questionnaire. We asked the 2 validated food questions, again, to cut down on the burden, and you can see that 61% of the families overall experienced some food insecurity. This was much higher in the urban community than in the rural community, but still very significant in both communities. And food insecurity was significantly rated to increasing experienced stress, so that there's a huge relationship there, and I think needs to be thought about in what we do next. And again, here's food insecurity by rural-urban. You can see that urban families much more likely to experience food insecurity. When we did our focus groups, we really found that they had different coping strategies in the urban areas versus the rural areas. The rural areas were doing a lot more trading, bartering, gardening, hunting, gathering. Urban families didn't have as much access. Some were using more food pantries and other kinds of things, and did some trading and back to their reservations or pueblos, but not nearly as much as when they were in the rural areas. I'm just going to go through quickly some child diet. You can see that the really low-income families had significantly higher rates of some of the things that we would consider to be sort of obesogenic foods, like the fried foods and the sugar-sweetened beverages, and much lower intake of water as a nutrient. It's very similar with adults. And then some activities that differed between families by income level. The families that were a little bit higher income, the child ate breakfast more often, had more monitoring of junk food, spent more time together doing things, and the child was enrolled in sports. But they didn't have any difference in sleep times or eating with the TV on or eating together as a family, which I found really interesting and I think reassuring. So conclusions, we were going to talk a little bit about the challenges of a 5-site randomized trial. We can do that maybe in the Q&A. Very significant site differences, which I will not discuss because that's something we've talked about with the tribes, but they are quite different sites. And I think what we're learning basically in American Indian country as well as all over is that obesity is extremely complex, that BMI is a very inadequate and insensitive measure, especially this early on, and that this is a really target age group, and I think very important, but also has a lot of prenatal influences, and so maybe hard to show changes. But the families were very engaged and interested in doing this work and teaching us a lot about how they've coped and how they use the materials, and so we're very excited about that piece of it. And I think the excitement generated by getting things into the home, particularly the books and other interactive materials, made a significant difference in many things. So I'm going to turn it over to Scott, who's going to talk a little bit about our journey together, and also just other great things that Menominee is doing, because of course many of these communities have their own other programs that interacted with this that are terrific. So take it away, Scott.
All right, thanks, Alex. Before I start, I just want to say if anybody went to the morning session, I've been working for 21 years and I've lost my marbles several times. But working with Alex and working with her staff, you can tell they're doing things right. I distinctly remember her coming to the school board, talking to the legislator, working with my wellness staff as far as working with the safety modules and figuring out what needs to be in place for that to work successfully. So when we talk about two-way street and learning from each other, I think UW-Madison is doing a really good job with that. Okay. Yeah, I know I really have a little bit of time before we get to Q&A, so I will talk very briefly. And I don't have any slides because I was expecting to be in the seats that you are. Alex invited me to come talk with her, so those look comfy after lunch. But yeah, we started in February 2013. Like many of you, I wear many hats. I'm also the WIC director for the tribal clinic, and in Wisconsin we have a peer breastfeeding counselor program with a WIC program. And so our peer counselor, our breastfeeding counselor who works with moms, works with kids already, she was a natural fit to be the site coordinator for this project. So Bethany Miller, who's one of my employees, has been from the start working with Madison and has a long-standing relationship working with her. When we found out what she did was she started recruiting with the WIC families, but most of these participants actually came to be part of the program through a Head Start Parent Nights. She went there, talked about the program. That's how she got a lot of her recruitment in. A lot of Head Start parents are looking for what's best for their children, and this seemed like a natural fit for those families. When we talk a little bit about those baseline results specific to Menominee, a couple of things came out for our group. We had 86 families that were recruited, and 30% of the adults were shown to be overweight, and 50% of Menominees in that program were obese. In the children, though, it was 20% overweight, 20% obese, so 60% fell in the ideal BMI range. So again, are we focusing on the negative or are we focusing on those positives? So 60% of our kids doing great for that health risk factor right there. 2.4 servings of fruit and veggies were consumed in a day for the children, just slightly below the 4.4 to 5 servings recommendation. And unfortunately, the soda and sugar-sweetened beverage intake in our Menominee children was an average of 9.9 ounces per day. So when we look at not just soda, but sugar-sweetened beverages, that's a lot of simple sugars going in. And this does take into effect that a lot of that baseline data was done during the summertime. And what we found out with our Head Start families is that the children do a really good job once they're in that structured Head Start environment, healthy meals, healthy activity. I do BMI data in fall, and I do BMI data in spring, and you can usually see that BMIs start to normalize once they're in a structured environment. Alex touched on the lack of sleep, and with these children, they're growing in their sleep, they're growing all the time. 10.1 hours of sleep per night compared to the recommendation of 11 to 12 hours of sleep. So again, if I'm going out late for an errand, I'd see some of these children out and about at 9, 10, 11 o'clock at night. So really working with the families to get that sleep regulation back in place, because if you're sleep deprived, as many of you are from the late flights last night, you know what you're feeling right now. Imagine being a 3 to 4-year-old trying to learn, trying to socialize, trying to interact appropriately. The families that were recruited were mainly millennials, so they really enjoyed the text messaging and the social media. A lot of them found that very useful and kind of triggered their memory as far as what they were supposed to do. And then the Menominee, we have what's called a community engagement work group. So we took agency leaders and we got them together to figure out how we can work together to solve some of our problems. And then childhood obesity and their wellness was such an important factor for them that they considered that as one of the 3 main focal points for the initial community engagement work group. So we actually have breakout sessions where we do 90-day action plans, figure out, here's our end result. This is where we want a healthy future generation of Menominee children. How do we get there? And we don't know where this is, but can we do 90-day plans to move us closer, baby steps closer to that end result? So every 90 days, we're getting together, all the agencies, and trying to get together to figure out what is working and what's not working in the Menominee community. And recently, our newest partnership with Alex and the UW-Madison staff is that we actually have a obesity prevention initiative that we renamed the Wellness Initiative. And we have, we're using collective impact with the agencies, and we're using community organizing. So we have a great community organizer who goes into the community, part of the community, and listens. And that's what we hear from him as far as what needs to change. And a lot of times they're already making the changes. They're not waiting for the agencies to catch up to them. They're already doing things. So I think that's really vital, and I think that's how Menominee is going to be successful in the future. And I see we're basically out of time. So thanks for that really brief snippet.